Dr. Indubhushan laid out the huge canvas of India's public health, as well as healthcare infrastructure, as well as the programs that are linking the two. But that linkage has not always been easy. We have had, for example, the National Health Mission dealing with public health and primary health care, whereas clinical services were actually the remit of other departments of health. And there was very little contact or connectivity between the two. And that has been partly also the bane of India's health service. But now we are seeing, even within the Ayushman Bharat, the health and wellness centers and primary health care being accorded importance, and the National Health Mission, which manages them, is also being brought close to the PMJ, which is providing the hospitalized clinical care. And therefore, bringing these two together is going to be an absolutely important move in advancing India's health. And that is where, to ensure a life course approach which provides preventive, promotive, diagnostic, therapeutic, rehabilitative, and palliative services across the life course of an individual through a health system which provides comprehensive health services. And that is where I believe we can actually ensure that we can address the complexities of both clinical care and public health as they form that continuum. Even when we look at where the complexity arises from, when we are looking at a person and an individual in terms of that person's biology, we are seeing that there are multiple layers: the DNA genome, the RNA, the proteins, the metabolites, the immune system, the microbiome, and much more. And this is where we are calling it as the metagenome, with the microbiome also coming into play. But at the population level, of which this individual forms a part, we see health being impacted upon by social, economic, cultural, commercial determinants of health, which interact to produce the conditions which enable or erode the health of an individual. And therefore, we are talking about what's called a super phenotype. And therefore, when the metagenome interacts with the super phenotype, then we determine what the balance between health and disease is. And these are the complexities of human health. But even at the level of the health system, we find that the context is changing. We are seeing demographic transition of aging populations, nutritional transitions with increasing overweight and obesity, epidemiological transitions coming up with chronic diseases, and health transitions, which are actually bringing in different forms of management of health, and particularly in terms of much more patient-centric rather than physician-centric care. And therefore, when we are moving from reactive sick care to proactive management of keeping people healthy, and from fragmented to integrated care, to try and see how best we can address that complexity with solutions which are both effective and are not time consuming. So to resolve that complexity for speedy decision making that delivers the best possible health benefits, we do require artificial intelligence as an ally. In fact, the whole spectrum of digital health, from predictive analytics, devices, pattern recognition, diagnostics, electronic medical and health records, robotics, telemedicine, sensors, smart home care. All of these Therefore, AI can help in service planning, supply chain management, public health policy, shaping behavioral change, whether it is drug adherence or wearing masks. Behaviors are going to be very important factors. And in order to gauge what are the prompts for behavior change, which act at the population level, at the individual level, again, we can actually access the strength of AI. And we can also have better resource allocation and delivery with better health outcomes. We need to distinguish, however, between the taxonomy of applications, which is theory, and the on-ground reality, which is practical. What is the best fit between an innovative application and the need on the ground? We must define the criteria for inclusion in clinical practice or a public health program. And for this, how do we evaluate? When do we scale up? How do we scale up? We have institutions elsewhere for example, the National Institute of Clinical Excellence, or NICE in the UK, or the HITAP in Thailand, which do health technology assessment. Now, we do not have equivalent institutions in India, but public health, with its multidisciplinary strength, can step into that picture for positioning technologies appropriately and affordably in the whole health area. Public health research can help in evaluation of health needs, health benefits, cost effectiveness, practitioner acceptance, and patient and community acceptance. All of these are important elements of healthcare which are not necessarily dependent upon individual technologies, but collectively can be facilitated by integration of multiple sources of knowledge, which AI can facilitate. And therefore, this calls for multidisciplinary collaboration, and public health offers the perfect platform for that. So whether it's a primary care or hospital setting, we do need that collaboration between technology developers and innovators, healthcare providers, health system managers, public health experts, health economists, social scientists. And public health and our own institutes of public health in India, which offer this multidisciplinary platform, can bring about this kind of a marriage between different disciplines in order to advance health as speedily as possible and as effectively in terms of its delivery and impact. We can have a winning team. But there are issues to be addressed. First is data architecture and interoperability, addressing privacy, regulatory, security, and business models. These are going to be important as we move along. Interoperability becomes especially important in low and middle income countries where much more happens at the micro level because you do not have organized systems of delivery, but there are many players at the micro level. Data governance becomes very important, balancing between privacy standards and responsible data sharing. These are going to be very important. And local data are going to be needed because context matters, particularly in health. We cannot have the artificial intelligence algorithms that have been developed in the West automatically transported into India. We know, for example, what's happening because of facial recognition algorithms in the West, which are essentially made for white males, and they do not function very well for others. At the same time, you cannot have algorithms which have been developed on the basis of limited population samples of segments of population only. Like, for example, you can have, looking at what banking algorithms can have, or private investment, private wealth investors, they can have separate algorithms. But healthcare is everyone's necessity, and healthcare involves everybody. Therefore, whatever you do in terms of your development has to have data which is very widespread and representative of the population. And therefore, we require Indian data and multidisciplinary data at that. And we need very effective integration of that. And that's where all of us need to get together, and public health can provide a very effective platform. And we do need also to take care that these algorithms do not have a differential overuse, but are widely applied. Because if there's a differential overuse with limited input feeds, then that input feeds back into the algorithms and reinforces the original bias. Therefore, we do need to apply it also widely, right from the subcenter to the hospitals, and then see how best we can actually develop the right kind of AI applications for each level of care. And therefore, we also need periodic checks, updates, and revisions which are needed. And the logic of the AI algorithms must be shared. It cannot remain a black box. It has to become a white box where there is a great deal of sharing and potential modification. So I believe as public health and clinical medicine come into one seamless union under the new health programs of India, stretching right from the individual sitting at home to the community into which that individual is embedded, and from the health sub-center to the hospital, we do require that artificial intelligence not only blossoms, but becomes also highly contextualized and takes into account the Indian reality as it keeps evolving. Because just as Indian reality is not going to be static, AI and its algorithms cannot also be static. So I believe we are in for exciting times with wonderful partnerships to come. Thank you very much.